thrilled to have Michelle and Holly. And today we are going to learn about some changes that have happened and that are happening on drug price negotiation. And there is not two better people in the world to talk about this because they're both trained pharmacists and very thoughtful in this area. So let me welcome Holly and Michelle to the stage, and we will kick this off. Great to see both of you, Michelle, and those of you who follow our discussions. You may recognize Michelle from some previous discussions that we had. I'm thrilled to have both of you with us today. And before we dive into these, historic drug price negotiations, let's get to know the two of you a little bit better. Michelle, I'll start with you. Tell us a little bit about your background and how you got into this world of pharmacy.
Sure. So my background's strange. I went to pharmacy school to be an astronaut, and that didn't work out. But I have specialized in people over 60 my entire career. I've been a professor for all sorts of different sorts of health professionals. And then I left all the normal stuff to become an entrepreneur about 9 years ago. And I now have a program called Propel Comprehensive Wellness because I saw a need for people nearing retirement to have a solid plan for how they're going to stay healthy, find new relevance and purpose, and make all the great choices for a long life ahead. So
I love
thank
it.
you for the chance to be here, Steve.
I love it. And Holly, tell us a little bit about your background.
Well, I knew when I was in high school I wanted to be a pharmacist, and so I went into it on the front end, working to get into pharmacy school. And in between undergrad and pharmacy school, I ended up working in a long-term care pharmacy as a technician and fell in love with that end of pharmacy. I also helped take care of my grandmother who lived with us when I was in high school and managed her medication. So it went kind of fell right into place. And so when I finished pharmacy school, I went straight into consulting in long-term care as a pharmacist, and I have done that my entire career. Now, as I'm getting on in years, I am working part-time for a long-term care pharmacy, still consulting, but I have ventured out on my own some now and do some independent consulting for individuals in the community for that want to do look at their drugs and make sure that they're doing okay. Also, I had been doing a lot of assistance with helping folks pick their drug plans so they can afford their medications. And so I'd been doing that for years, but then realized I could get my health insurance license. So I did.
Wow.
And now I can officially say I can help people do that. So
I love it.
that's where I'm at right now.
And
And I vaccinate a lot too. So
oh
I go
wow.
out into communities, older adult communities, and do vaccine clinics for several pharmacies.
Oh man. Well, you all are feet on the street when it comes to this, and so I can't think of any two better people to introduce what's going on in the world of prescription drugs. And so I know you've got some slides that you can share. So why don't we just jump right into it? And then, folks, the best part about our discussions is they're live and interactive, and you can ask questions at any point in time. And Michelle and Holly, I'm going to duck behind the curtain here, but feel free to just check in with me, and if I'll let you know if there's any burning questions that we need to answer.
Awesome. And we will, because we really want to hear from everyone that's in the audience today. So we'll talk about this historic price negotiation. What is happening? Let me go ahead and move forward. Give you a timeline and let you know what are the first medications that will be negotiated and what that might mean for you as an individual. Then we want to, if there's time, talk to you about open enrollment that's right now for plans for 2025, because there are a lot of changes and we want to make sure that you're aware of those before you finalize your plan selection. And then other information, Holly and I, you're going to learn, could talk to you for days. And so we're going to try to keep this in the timeline that we have, but we welcome your feedback and your questions as we go. So Holly, I'm going to set you up. The
Okay.
Medicare price negotiations, what has been the timeline? How have we gotten to this point? And then when does this actually impact us?
Well, obviously, we've had a lot of discussion in our federal government with the Inflation Reduction Act, which actually had a lot of stipulations for Medicare coverage. And basically, they started in 2023. CMS published a list of the first top 10 medications that they wanted to negotiate the prices of directly with the manufacturers. The way they chose that is they looked at the top drugs that they're spending money on for their covered folks, and so they were looking at costs, but also some that the very common drugs that are being used. They focused on drugs that are brand name only. So of course they're going to be much more expensive. And
Right.
so then that can benefit the Medicare recipient and help them save cost as well. So they met with manufacturers. They've actually met with consumer groups, individual patients to see what they were wanting to, what would work for them, their interests and ideas. So then they negotiated with those drug companies. And that was quite a bit of time, and they did a lot of back and forth. In August this year, they published the negotiated prices that they had come up with for those drugs. Now, these drug prices will not kick in until 2026 Medicare. So
Right.
there's a lot of time between that. So we don't know necessarily if the negotiated prices that they published in August will remain the same or could end up being different. So we always take it with a grain of salt. But the goal for this negotiation is to help the consumer save money. Now, in reality, how easily that's going to happen, we're not sure yet. So I think a lot of this is wait and see. That's kind of where we got to this point. So those top 10 drugs, everybody's excited. And I'm very excited about it because they chose some really expensive medications that we utilize all the time, but we're not going to get that benefit until 2026.
So just to clarify, so some of them are just incredibly expensive medicines. And some of them are expensive medicines, but so many people use them, the cost to the government is very, very big. So those were kind of the initial selection criteria for this very first batch, if you will, of medication. So walk us through. Let me explain first. This chart is what was published. And I know it is very small and hard to read, and I don't want you to feel like you have to read it, but I just want you to know that it exists. So it lists the medications, it lists what they're used to treat, what kind of medical conditions, and it lists what are those negotiated prices. Now, these are the prices the government, CMS, will pay for the medicine. It doesn't yet say what you will pay as the consumer, but this is what the government will pay. Am I correct?
Yes. And so there's that in between situation, and how much the insurance pays versus how much the consumer pays versus how much the pharmacy gets paid. So that it gets complicated. And we're going to try and go over a little bit of how drugs are priced a little bit further on in our discussion. But so no, we're not all going to be paying $115 for the Jardiance. But they're going, it's not as simple as saying you're only going to pay $35 for insulin, like they did with when they first did the insulin and said, basically CMS said we're only paying our consumers are only paying $35, and they had to work with that. So this is going to be a little different. So, and it could be a variety of things. We're just waiting to see.
We're waiting to see. So walk us through what are these 10 medications, and which ones do you think will impact us individually the most?
Well, basically the way it's listed there is looking at the expenditures. So that the first drug there, Januvia, it's a great drug. It's to treat diabetes. It is a newer drug, so it doesn't have a generic. But it's pretty much in our standard go-to treatment of diabetes now. And so it's used very often in our type 2 diabetics. So it costs a lot of money to the government when they add it all up. So that will definitely impact a lot of older adults that are on Januvia and are Medicare recipients. Then the next one is more of a, these are the Novo Nordisk insulins. So they are mainly the short acting insulins that are not currently under the $35 cap. These are a little more unique. There is a cap on, say, Humalog, which is a short-acting insulin by a different manufacturer. That's under the $35 insulin cost. So they're just adding in the Novo Nordisk's insulins to that list. So that will increase the number of insulins that are covered. Farxiga, again, is a diabetic medication. However, we also have found that it is excellent working in patients that have a heart failure. So it can be used for a couple of different things now, and they also go hand in hand. So it's one that we're seeing a lot of people be started on as well. Now, the next one is one we don't see as much. It's not that common, but it's very expensive, and that's Enbrel. And Enbrel is used for rheumatoid arthritis. That's its most common cause, and it's an injectable once a week. So it can add up quite a bit, and it's difficult for a lot of folks to get that to pay for that. And if you can read the little chart there, the Enbrel, the negotiated price is almost $2,400. So that tells you how much it is in reality. So, and Enbrel does not have a generic. So I think it's excellent that they're negotiating that because it's a good drug. It's been around for a long time. So, so yes, definitely will be helpful. The next one, Jardiance. Again, another diabetes medication. So it's again kind of in that realm with all these new diabetes medications that we've seen come on the market in the last few years that are excellent and safer a lot of times to treat type 2 diabetics. They don't tend to have as higher risk side effects, such as dropping your blood sugar quickly, where you may, if you don't eat, it could be dangerous, that type of thing. So there's again another diabetic drug. The next one's Stelara. That's actually a psoriasis drug. So again, not a lot of people on it, and I'm sure you've seen the commercials on TV for Stelara, but it's extremely expensive. And it looks to be what the list price is about $13,000. So yes, in there again, if someone is using it and it's very effective, you want them to be able to afford it. But that's one, it's not as many people on it, but very expensive. Xarelto and Eliquis, those two are probably the ones that are the most exciting that will be getting covered from our standpoint in long-term or in older, treating older, the population. So Xarelto and Eliquis both are blood thinners. So in the past, we did not have a lot of options in blood thinners, a lot of lab work that had to be done, a lot of dose changing that had to be done and had to be monitored very closely. But these medications, they can do the same thing, but we don't have to draw labs.
Whoops, you're frozen, Holly. So yeah, these medications, just real quick, these medications are for preventing blood clots. So
yes,
a number of people have had heart procedures or they've had a blood clot and they're preventing another. And I'm sure many of the people in the audience remember warfarin or brand named Coumadin, and that's the one Holly was referring to, that required a lot more close monitoring. So these medications have opened a new door for some safer medications, but super expensive. So we're glad they're on the list.
Yes. They're also, if you have a diagnosis of atrial fibrillation, they are used for, in those folks that have that, to help prevent having a clot or a stroke. So it's a preventative as well. So it's one that there's many folks have AFib. And so that's pretty much the gold standard now. And very expensive when it comes to looking at how the drug coverage the coverage on their prescription drug plan in Part D is. Those are usually the top two that I'm looking at to see, okay, which plan covers which and how much,
Right.
to how to direct folks as to which ones to, what plans to look at. Because those are drugs that you don't want to not take.
Exactly. For life
You
saving.
may not be
Life
feeling
saving.
the effects of the medication, but that's actually really preventing a life threatening event, or reducing your risk for that. So Entresto is another newer agent. It's for heart failure. It is a combination medication, and it's definitely been one that's been utilized quite a bit since it's come out for those folks that have the chronic heart failure that need that the current meds they're on are just not taking care of it as much. And so it's giving people a much better quality of life. And so they're more active, because of heart failure, it's very tiring. And if you can't get out and about, it limits your quality of life. So
Right.
Entresto is definitely one that's helped, is important as an add-on for those folks, so they can to remain out and about and live their lives without having to worry about not being able to walk across the room. So now Imbruvica, that's the one that's the only one on here that's for cancer treatment. And it is mainly treated with leukemia, lymphoma. So obviously that's not a huge population of people, but extraordinarily expensive. So that's why that one was included. But those are, and it's an oral medication, so it's not a chemotherapy agent that you would get when you would go into an office and have an infusion. It is an oral agent, so you would take that by mouth every day.
Right. If you have trouble seeing the chart, that one's almost $15,000 retail, and the negotiator price is a little over 9,300. So very expensive. But my goodness, if you've got a blood cancer, you want every opportunity to control that. So this is a good point, Steve. Do we have questions or comments at this point that we could address?
Yeah, Glenna says, I can vouch for the value of this kind of pharmacy consultant that Holly's talking about. My mom was prescribed a drug that the side effects had been so bad that it nearly forced her into assisted living because it made her too groggy. The pharmacist told us about another medication she could take that didn't have those side effects, and it helped her live independently for another 6 years.
Oh my goodness.
Yeah. I mean, I love what we're talking about here, because it's like um, it's all mixed. Everything is so confusing. It's, the drugs that we need to take, the drugs that we're currently taking, how much they cost, what's covered under our health plan. It's really very confusing. And let's see, Zahida says, does Sparks
Farxiga?
FAR, yeah, does that have a different name?
That's the brand name. It is only available in the brand name, but the generic name for it is dapagliflozin. It's a flozin, as we call it in the pharmacy trade. It's in that class of drugs. No, it does not have a generic
Okay.
available.
And then Zahada is also asking, and Jardiance?
Guardians?
Yeah, does that have another name?
It does.
Again, let me, I will, that's empagliflozin.
Empagliflozin.
Empagliflozin. Yeah.
Empagliflozin.
That's in the same class as the Farxiga. But again, both are brand name. And I don't believe we have any generics in that drug class currently. So that's where, again, these are excellent drugs, but still very much on patent and very expensive.
All right, she thanks, Zahida thanks you. And then I knew this question was going to come, and if Kelly wasn't asking it, I was going to ask it. And you may bring this up in some future slides, but do you folks anticipate any additional changes based on last week's election results? You don't have to answer it now, but if you want to answer that at some point, that would be really interesting.
Well, I would say it's still a work in progress. It's hard to know. either way. I don't think either one or the other would have been a great win versus a great loss. I think they both are both parties are looking to help cut the cost there. It's just about how they might be going about it. So the intention is there. I'm not sure exactly though how it will affect that. So that's one of those we're gonna have to wait and see.
Great. All right.
And
Well, yeah, we got through our little pile of questions so far.
And I think we do have a slide coming up that we don't know what either party would do with this issue, but we're going to raise an issue for your awareness, and we're going to be watching with you to see how it gets addressed.
Okay, great.
So these are the medications that will be available under some sort of negotiated price starting January of 2026. And we don't yet know what the consumer price will be. So we'll kind of all keep an eye on how that's going to look. But it doesn't stop here, or the current plan is that it doesn't stop here. So in February of 2025, CMS has another 15 medications. I'll get to my comment in a second. Another 15 medications that they're going to take to the manufacturers to start this process of price negotiation. And then they will publish the prices that they agree to. And then those will be available the next year, January of 2027. And what I was going to say, Holly, I anticipate they'll be in those same areas of like rheumatoid arthritis, Crohn's, psoriasis, all those autoimmune disorders, or heart failure, plus minus diabetes, or cancer. Would you say probably those kind of categories?
Yes, we may add on some COPD, so some of the inhalers that are the combination inhalers, like the Trelegies, the Breztrees, things like that, that do not have a generic form available for it. So they may show up, they may not, but those are, expensive drugs that you have to keep in mind when you're choosing your prescription plans, for sure.
Excellent. So now we want to dive into another couple of topics. We feel like these are important things for all of us to be aware of, and we're going to do our best to explain them. So on the news, you're probably hearing about pharmacy benefits managers, or PBMs, some positive news, some negative news. So, and I'll start with the PBMs. Their job is to coordinate pricing and distribution of medications between drug companies, pharmacies, and insurers. But Holly, give us a better understanding of where did this come from, and what's its role supposed to be, and then maybe some things we should be aware of.
Well, essentially, the PBM is the middleman. So the PBM is the one that negotiates prices with the drug manufacturers. Then the PBM decides how much the insurance company has to pay. So your carriers such as Aetna, United, Humana, Cigna, all of those. And then the PBMs determine how much money the pharmacy gets in return and gets paid basically by to sell the drug. So the copay typically is going to be the same for the individual. They may be paying a $0 copay, a $5 copay, $10, or they're paying potentially a 20% cost. But the PBM determines how much that pharmacy gets reimbursed on top of what the $10 copay they just got. So where we've run into issues with the PBMs and why it's being talked about so much right now is that some of these PBMs are owned by either an insurer or a pharmacy, or kind of they're all three. So the top three PBMs that are utilized in the country to set prices and reimburse pharmacies for what they get paid and what the insurer gets paid is number one is CVS Caremark, that PBM. It owns CVS Pharmacy, and then it also owns Aetna Insurance. So if you have an Aetna insurance plan, there is a reason why they want you to go to CVS, because they own it. And so that's one. Another one is OptumRx. That's another PBM that's owned by United Healthcare. And the third largest is Express Scripts, and that is owned by Cigna. So yes, there's a lot of commingling in that respect. And there is not a lot of transparency in how these PBMs determine who gets paid what. And so the one thing that is very apparent is the PBMs will reimburse their preferred pharmacies, i.e., a lot of it, their own pharmacies. They'll pay a lot more for the drug, to pay CVS a lot more for the drug than they would if you went to another pharmacy, such as a Walmart or a small regional chain, or your independent pharmacy that's in your town that's been there for 60 years. And so the thing that scares us as pharmacists these days is that some of the reimbursements that the PBM is reimbursing the independent pharmacies on the cost of the drug is actually less than what it costs them to acquire that medication. So they're actually losing money by selling that drug to their customer. And so they have to determine, do they want to continue to do that? Or do they say, do I let their customer know, I'm so sorry, I can't fill that one for you because I'll lose money. And it would be better for me if you look for another location to get that one particular drug filled. So it's causing a lot of independent pharmacies to close their doors after decades, and creating what we call pharmacy deserts in a lot of smaller rural areas where they don't have a lot of options to get their medications filled. And so they may have to drive further to get those medications, or they end up using mail order pharmacy. And so it's not a lot of good options. Right. That's where the PBMs are in the news the most, but also too, each state, it seems like, is trying to do some regulation on these PBMs to make them be more transparent in their pricing and the negotiations, so people can make a much more informed decision. And lots of states are trying to get bills passed now. I know in North Carolina we are. I know there are some states that have already passed it. And I do believe it will be something that will come up in this next administration about looking at some kind of federal legislation. What it will, we don't know. But it's definitely being looked at.
Exactly. Let me just point out a couple of things. My biased opinion, perhaps. So I've been a pharmacy professor or other health professionals all my life. And one of the most important details is pharmacists understand the medications at much more detail than the rest of the healthcare team, because that's our role. Our role is to be the medication expert and to make sure that that gets translated from the prescriber to you as the consumer, that you understand the medicines you're taking. In general, independent pharmacies tend to differentiate themselves by providing more of that kind of service and explaining the medications, being available to review your medications with you, make sure your supplements and other things you take are safe with those meds. Most of us have many more than one doctor. So the pharmacy is the place where all of the prescriptions come together, and we can make sure everything is right for you and not going to cause the situation that was talked about earlier, where the side effects were so bad, somebody was thinking about assisted living, where if we just, what I call, clean up the medication regimen, we can get rid of those side effects and give people a much more autonomous and high quality life. I mean, I've got hundreds of stories about doing that. So I believe it's a huge disservice to society to allow this to close those pharmacies, to make people in more rural areas depend on mail order. And if you get an acute illness, you break your leg and you don't have a pharmacy in your town, last thing you want to do, you're going to have to go with your broken leg however many hours to a big city and navigate the city to get to a pharmacy rather than have access to pharmacists and pharmacies in your own local area. So for so many reasons, I think this is a huge deal. So let me stop there, Steve. Have I overstated? And are there any questions around that?
Oh no, this is great. Okay. Let me jump on a few questions we've got here. Cheryl asks, although medication is being negotiated, the costs are still too high and unaffordable. I lost a dear friend because she could not afford her diabetes medication. Even when the hospitals recommended her come to the ER for treatment, eventually those attempts failed. What recommendations are there to address patients limiting the usage of medications because of cost? Oh yeah, the choice between cost and food and all that. Yeah.
That's always a beautiful question. And there are still the much, much, much more affordable medications. And these medical conditions can be managed with those. You just lose some of the benefits of fewer side effects with some of the newer medications, simpler dosing with some of the newer medications. Like Holly was talking about, some of the diabetes medicines we're finding it also protects your heart and it also protects your kidney a little bit more than the older medicines did. But my opinion is an affordable medication that can manage the condition is way better than an expensive medicine that you're not going to take because you can't afford it.
Exactly. And I think too, when I hear of people saying, well, I can't afford all of my Jardiance this month, so I only bought 15 of them. And so I'm taking them every other day. That the benefit you're getting from that is not that good. There are other options that are cheaper that you could go back to and be able to afford and then have a more consistent treatment. But I would say communication with your doctor. Number one, if you get to the pharmacy and you are shocked at how much it is, you need to reach out to your provider and say, I cannot afford this. Is there an alternative? And the rub for Medicare recipients is that, and a lot of doctors will say this, oh, well, there's a discount plan or code or coupon that you can use. Unfortunately, if you are a Medicare recipient, you are not allowed to use one of those discount coupons. So the doctors a lot of times thinks, oh, I can just give them a discount card and then they can afford it. And that's not the reality. So that's where you need to, again, communicate with your provider to say, I can't use that. Can you please look at something less expensive? And go from there. Also, being able to talk to your pharmacist and say, look, I cannot afford all these medications. Is there something I can do? What would you suggest? And that's where then they can give you specifics. And if I looked at your list of meds and say, okay, this Jardiance is the one that's costing you the most money, but I don't see that you have any allergies to a sulfonylurea, like our old standby, like glucotrol or glipizide. Then have you ever taken those? And if that might be something you would ask your physician and go from there. I mean, there are pharmacists out there, not a lot of us, but that will consult with folks and go over their medication list and reach out to doctors for them. I have done that many times. I know Michelle has done that. And we're not as available, really. We're out there. If anybody asks me, I'll do it. But these pharmacists that are in these big, large retail chains, unfortunately, are not being given the amount of time to take to do that service because of their work load. And it's unfortunate. And I know there's a lot of pharmacists out there that want to help their customers, but yes, are not able to because of their constraints. So I say go to your, I'm not so concerned about which pharmacy you go to, as long as you feel that you can ask your pharmacist a question and they will take the time to answer it for you. Exactly. If they don't have the time or don't want to, then that might be looking at, do I need to switch pharmacies? Because again, you want to have a trusted person that you can call and ask a question and they'll give you an honest answer.
Right. And we're kind of going to go into that. This is our last slide. So I'm going to jump ahead to the bottom of this slide and then Holly ask you to walk us through what to look at in open enrollment. But just exactly like Holly just said, in the year ahead, when you've got a new prescription, make sure your prescriber knows what plan you're on. And if they prescribe a medicine and you get to the pharmacy and you're like, wow, I did not expect it to be that expensive, I can't afford it, then ask the pharmacist to give you other options that you can take back to the doctor, or ask the pharmacist if they'll call the doctor and discuss other options for you that are more affordable. So don't feel stuck, and certainly don't walk out taking nothing because you can't afford it, because there's almost always some other options to consider. So Holly, tell us about open enrollment, because it's now. It's just
It is. Traditional annual enrollment for Medicare recipients starts on October 15th and goes to December 7th. And so that's when anyone that receives Medicare A and B, is on a prescription drug plan or a Medicare Advantage plan, can change their plan if they want to, or keep the plan that they want to, to start in January of 2025. My recommendation this year for sure is, even if you're extremely happy with your drug plan and it's covering all your drugs and that type of thing, you still need to reevaluate it this year to see if the plan that you're currently in is the best option, because we've got a lot of changes for this year. And for on the consumer end of it, it's a positive change for sure. So when people heard the term donut hole over the years, when we have those the Med D prescription plans came out, and people never wanted to hit that donut hole because the meds went up and then they would never hit the catastrophic. Well, the Inflation Reduction Act took away the donut hole. So now you either are in your main benefit, or once you hit $2,000 out the $2,000 cap for the year, you don't pay anything for your medication. Your drug plan will pay for the rest. And so depending on the medications you take, if you're on expensive drugs, and you can say if someone's on Eliquis and Breztri, those two medications alone, you will probably hit your catastrophic coverage in May. And at that point, you're not paying anything for medications. Now, you may be paying your premium that's for the Medicare Part D plan that you chose. So you may be paying $50 a month, but that's to keep your coverage, but you're not paying for drugs. And if you get a new prescription in that time frame, and once you hit that $2,000 cap, you're not going to pay for that new prescription either. And it goes through the year. Of course, it resets at the beginning of the year. So that's different, and I think can be very positive for a lot of people out there.
Now, the $2,000 is across the board. It's not plan specific. This
No,
is
it's
part
across
of
the board.
negotiation. Everybody's maximum out of pocket for their medication will be $2,000 as long as it is a medication in their plan. Can you explain that? What if the doctor prescribes something expensive and it is not covered by my plan? What will I pay?
So in each prescription plan, they have a formulary, and they're each a little different. And again, the PBMs are the ones that choose the formularies for the most part. And so if your doctor writes you for a drug that is not, if it's a brand name drug, if it's not a preferred brand or not even a specialty drug for them, they just flat out say, we don't cover that drug. Then if you continue to stay on that, you're going to have to pay out of pocket the total cost of that drug. Now,
which could be catastrophic financially.
Exactly. And 9 times out of 10, it's a matter of letting their doctor know and saying, okay, let's figure out what is on the formulary, that type of drug, and we will switch you to that. Because the formularies, they are required to cover individual medications in each drug class. They're not required to cover every drug in a drug class. But say statins are an easy example. They're all generic now, but it used to be that, there's 5 or 6 or 7 different statin drugs for cholesterol. Well, some were brand name only, and that would not be on the preferred list. And so if the doctor wanted you to stay on that particular one, you would have to pay a lot more money for that. But 9 times out of 10, most people can try another statin and they'll do just as well. So
Right.
again, it's a lot of options. So there's not a generic equivalent, but there are other options in the same drug class potentially. But
But it's
you
in
can
the
always
tier
ask.
of your plan. Yeah.
Yes.
I
Yes.
have two more questions for you. One is, I'm sure some people are thinking $2,000 in the first part of the year. I don't have that.
Mm-hmm.
I want everyone to remember this is the very first year of this. And anytime something is the first year, we're going to learn just how easy or hard it is. And there are probably going to be some hiccups.
Mm-hmm.
But there is an offer of a payment plan. Tell us
Mm-hmm.
generally how that works.
Okay. So this year, starting in January 2025, the term is Medicare Prescription Payment Plan. And essentially, how it works is you would decide if you want to participate in that. It's completely voluntary, it's not required. So, if someone has a large deductible on their prescription plan, say $590 that they have to pay before the insurance kicks in, that January prescription drug bill is expensive a lot of times. And so, if people, I think just in the way it's set up, is it would be much more beneficial for somebody that's on stable meds that are not taking or having a lot of changes in their medications. Things can be more predictable if you sign up for the payment plan. Basically, when you went to the pharmacy, you would not pay anything at the pharmacy directly to get your medications. You will be billed, and they will break that cost of your drugs out and spread it out over the 12 months. So to help ease that burden. Now, if you, I mean, again, it's involuntary. So you may decide that you don't want to do that. You might say, oh, in July, okay, I want to get on a payment plan now. Well, again, you're not going to get that benefit much until the end of the year. So when they're looking at the cost and dividing it out, it's less months. So I think it's very much person specific as to what medications you're on, but you can actually go on medicare.gov. And if you're trying to decide if you want to enroll in the payment plan program, it will ask you some questions to see if you are a good candidate or it would be beneficial for you or not really worth it. So some people that are taking all generic medications that are not very expensive anyway, it's probably not worth it, because ultimately you still have to pay for it, and those prices can change. Because if you get a medication added after know that, oh, I'm going to pay $85 a month spread out over the 12 months. Well, if you get a new drug added into that that's very expensive, that's going to increase your payment. And and if you miss a payment, then they can unenroll you in that. So again, it's new. It sounds intriguing, but I would say definitely do your research on Medicare.gov to understand the program and determine if you want to participate in that. I always like to let other people try it out first before I jump head first. You'll still be able to. You still will pay for your medications. It's just where you'll pay for your medications.
Right.
And two, another, speaking as the pharmacist side of me, is we're not sure exactly, because there's no requirement on this payment plan, how quickly the insurer or Medicare reimburses that pharmacy that just sold that drug. So they just walked out of that door with a very expensive medication. There's no guarantee when that pharmacy is actually going to get reimbursed for that medication. So timely reimbursement is a huge thing too. So I know independent pharmacies are definitely on edge to see, okay, how long is it in reality is it going to take them to get us the cost of the drug, because the pharmacy has to buy that drug up front from a wholesaler and put the money out for it. So that's going to be something to watch as well.
Excellent. And I've got one more thing. I'm going to try to explain it and then you clarify. And then Steve, we would love more Q&A. In the news or on the commercials, you're seeing a lot of advertisements about these Medicare Advantage plans where
Mhm.
everything's kind of rolled together. And it sounds pretty easy when you see those because, again, all the benefits kind of rolled into one place. And Trisha Cash, if you're listening, she's the one that caught that we need to mention this. If someone has had Medicare plus a supplement plus a Medicare D plan, but most importantly, a supplement with their Medicare plan, and they leave that for an Advantage plan, which is going to be a little bit more restrictive as to how many providers you can access. If you change your mind and you're like, oh, that was a mistake, I want to go back to Medicare plus a supplement, you have to undergo underwriting. So you have to get approved or qualified for the supplement again. But however long it's been, you've aged a little bit more and maybe gotten another diagnosis or two, and getting back into the supplement is not always possible. So this is a problem that has been identified over the last couple of years that we think people aren't aware of. Not to say that you can't do Advantage, but this is a consideration that people don't even realize they need to consider. Is that fair?
Yes. And I think with the traditional model of Medicare, most people are familiar with Medicare A and B. So A covers hospital, B covers doctor's visits. And then they cover 80%. So the consumer is required to pay the 20%. So where a Medicare supplement plan coming from a private insurer fits into that is you can enroll in that and you'll pay a premium each month. And whatever Medicare A and B does not cover, that supplement will pay for. And the nice thing about the supplement is you can go to any doctor that accepts Medicare payment. So you're not constrained to a network. So especially folks that live in the rural settings, they don't have a lot of options for doctors and stuff. Sometimes it's better to not be constrained into which doctors you can use. So it's for the older adults that are already on that, I think that it's safe to probably stay on the supplement plan unless there is a significant reason to switch to an Advantage plan. If they're comfortable with that, then I say stick with that. Then, of course, with the supplement, you still have to get a prescription drug plan because the supplements do not include drugs. And you are required to have a Part D prescription plan. If you do not enroll in a Part D prescription plan, you can be penalized for that and be charged a late fee. But if you're in an Advantage plan that has drug coverage, you don't have to. So in reality, you either have a separate prescription drug plan or you have a Medicare Advantage plan that has drugs included in it, drug coverage included in it. So what I see is kind of the trend and makes a lot of sense is Medicare Advantage plans are very similar to what we're already used to with our employer plans, where it's an in-network, out-of-network. We're used to a maximum out of pocket to pay for the year. Once we hit this, we don't pay anything, things like that. And so if you're just starting out to just turning 65 to enroll in Medicare, I think they're great options because they do include vision coverage and dental coverage, which traditional Medicare does not cover.
If you're in an urban area, not at all if you're in a rural area.
Right. So again, I think you need to look at the coverage. One of the things that I do when I'm assessing a plan, whether it's a Medicare Advantage plan or just a drug plan, I make sure I look at the doctors that you go, that you have, and I say, list every doctor that you go to. Okay, let's put those in. And when I go through my software and run it, it tells me which plans. So if it pulls up one plan, it'll tell me 5 of your 7 doctors are in the plan. So the goal is to make sure your doctors are in the plan. Otherwise, there's no reason for you to do the plan because at this point, you need to not change your doctors. It's, for health continuity.
So Steve, we've kicked over all sorts of cans of worms. What questions? have
This
we
is
raised?
great. And we got tons of questions here, and I'm looking at the clock. Looks like it's 5 minutes to 1 East Coast time. Are you all okay hanging on a little bit longer and we'll get through all the questions?
Yeah,
And
I'm
then
fine.
just to remind everybody who's on the discussion today, if we don't get to if you have to jump off, then you can watch the recording at proaging.com. Okay. Here we go. Robert says, how do doctors who prescribe keep up with all these changes, or do they just script what they're used to, or what is cheapest? And then how do we know?
A lot of times they don't keep up. I mean, as pharmacists, we have a hard time keeping up with cost of drugs. And so you will have some doctors that are very on top of that and understand the cost of medications. But then again, you'll have some that are not. That's why you need to advocate for yourself and ask questions. And that's where your pharmacist can help you, because as a pharmacist, I can look at a list of meds and say, I know which ones are the most expensive. A doctor may not be able to, because I know which one has a generic equivalent and things like that.
So now,
So
on that, like, is a good practice, because we've all been in that doctor's office and they hand us pieces of paper, there's nobody talking to us and this, that, and the other. Is a good practice to, like, when you get that prescription, number one, hey, is this the cheapest, this, that, and the other? But number two is just to simply say, either to the doctor or the person that you're leaving, I'm going to the pharmacy right now to get this filled. But if the pharmacist has any questions, what number do I call if I have a question or a concern?
I think that's very valid.
Okay.
And these days, you're probably going to be referred to your portal, to your my
Mhm.
chart kind of thing. And that is designed to be able to ask those questions and get a response if it can wait for 3 or 4 days. If it's urgent, we all know that this is not anti any health professional. We are advocates for everyone. We're in an odd time when the time of the provider is so restricted that
Mhm.
unfortunately them calling you right back or answering the phone is very difficult. So the more you can figure things out while you're in the office before you leave,
Okay.
the better.
Okay. Let's see. Robert gets a gold star today. He's got lots of good questions. Will there be a difference on med prices between Part D or a Medicare Advantage plan?
Um, yes, because again, the insurer kind of determines what they're going to include in that advantage plan. But on Medicare.gov, you can easily look and it will show you what the copays are for the different tiers. So basically, you have like tier one, tier two, tier three, and then usually it goes up to specialty. So the higher the tier, the more expensive the drug is typically. But when you're looking and assessing the plans assessing the Medicare Advantage plans, it breaks it out into the drug coverage component and will tell you how much your copay is for a tier one drug, how much your copay would be for a tier two drug. It'll even break it out and tell you what your copay would be at a preferred pharmacy versus a standard pharmacy. So that's where it's important when you're going to Medicare.gov to put in the pharmacy you prefer. And so then it can tell you whether that's a preferred pharmacy or a standard pharmacy. There's not a lot, most of the time, it's not a huge difference in price, but these insurers are incentivizing folks to go to mail order because it's cheaper for them.
Yeah.
And so they'll make that the most attractive. But some people are much more willing to pay a little bit more in a copay when they can actually have much more control over it and go and pick it up at their time to the pharmacy and not just continually getting drugs sent to them that may have been discontinued, and why am I still paying for it, and all of this. So I say it's important to be aware of your medications, and do what you can afford, but look at what you might be limiting yourself in when you do that.
All right. Now, somebody had a question about PBMs, and just as a reminder, that stands for Pharmacy Benefit Managers, and I dropped a definition of what that is into chat.
Oh, excellent.
And the next question is, how are discount pharmacy providers like GoodRx, Blink Health involved in PBMs? Are they included in the negotiations?
No. No, they're kind of their own thing, trying to be separate. And for the most part, those programs are typically utilized by people under 65 or non-Medicare recipients, because a Medicare recipient, you either use your insurance or you would, if, I mean, I say look to see, is it cheaper on GoodRx, but you're having to pay out of pocket. So you're not going through any insurance when you do the GoodRx, the, was it Simple Care, things like that. And so again, it's unfortunately a lot of it is you're just playing around and having to price stuff out to see which way is cheaper.
But we
Okay.
talk about uninsured and underinsured people, and they're probably the ones that get the most benefit from like a GoodRx, because everybody with Medicare is insured and will likely ultimately pay less.
Okay.
Right.
And,
But it can't hurt to look to price it out.
Yeah. Folks, we got a pile of questions, but Michelle and Holly are going to stay on. I'm going to try to get through all of them, because if you took the time to type it in, we want to at least address it. Okay. So just be patient and remember this is recorded. Let's see. Mary says, of course, I have to ask about GLP-1 weight loss drugs. On Ozempic, I wish I could get it in Germany for $59 instead of more money in US. It seems that WellCare and Aetna are now offering Monjaro too now. I'm wondering if I switch about cost, and given these things, I'm anxious about the plan choices. Any thoughts on the weight loss drugs for Mary?
One, there's a shortage because they've become so incredibly popular. And Holly and I were talking earlier today, the indications, the benefits of some of those medications are still being determined. And so they're being used for even additional things, which will raise the demand even higher. But I can never recommend that you necessarily order it from another source like that if somebody's not making absolute certain that what you think is in that product is actually in that product. There are so many black market schemes where you get a bunch of mud and you don't realize it.
Okay. Let's see. Tom says there are several Medicare Advantage plans closing up one or more of their plans in some areas. People in those plans get a get out of jail free opportunity to go back to original Medicare and a Medigap plan without underwriting. I know this is a little bit off topic, but do either of you want to comment on that? I was not aware of some of these plans closing.
Well, like everything, they reevaluate, and if they've got too many in one plan and they don't want to offer it the next year, they'll switch it, make it a little different. So yes, that's again why you want to reevaluate every year, because the plan that you're in currently may not be available anymore, and they'll just auto enroll you in the next closest one, but that doesn't necessarily mean it's the best one for you. But yes, there is a potential for that. But again, it's one of those that you're hedging your bets as to, do I want to leave Medigap to go to Medicare Advantage and then hope that they close up shop so that I can go back? You know, it's one of those, you can't count on it. But yeah, there's a potential there.
Sharna emailed in a question, and I'm curious on your thoughts, and none of us have a crystal ball here, but one of her concerns is that if it is sort of cost shifting, where the drug prices are lower for Medicare, but then the private sector, they pump the price up to keep the profits at the level they are. Any chatter in your world on that?
It can always happen. I'll give you an example of this year. So we've got that $2,000 cap. It's great. It's helping a lot of people. So who is that? So who's paying more money now? The insurer. Okay. Well, the insurer still wants to make money, right? There was no stipulation when they said you have to cap the cost at $2,000. It didn't say you can't raise the premiums.
So it
So what we've
didn't say,
seen
yeah.
across the board this year is the premiums for the drug plans have gone up. And so there's not near as many options available that are a zero premium. And so now you have to weigh the pros and the cons. Do you pick a plan that's got a premium, but you may be paying less for the drug? Or you pick a plan that's a zero premium, but when you put your drugs in, it's going to cost you a lot more for the drug. So again, that's where it's helpful to put that into Medicare.gov and look through it and see. And you can sort it by how much you're paying for the total year and things like that to help you understand that more. Or you can reach out to an insurance professional and they can assist you in that as well.
Okay.
This is
All
the
right.
year to do that because so many things are changing. Yeah, go ahead.
Okay, yeah, and folks, we're just gonna try to get through these, but remember it's recorded, so if you have to jump off. But let's see. I know you've talked about this, but I like Robert's question. So what is the best way to choose drugs based on prices? Any sort of words of wisdom out there for all of us tuning into this?
Is he asking to choose drugs or to choose plans, like your plan for the?
Um, maybe a little bit of both, because I guess they go hand in hand, right?
Yeah. So
So,
plans is exactly what Holly was saying. Either have someone guide you through Medicare.gov where you line them up next to each other and you see what your 2025 costs are going to be. And then if it's a new prescription, see how much your insurance will cover of a new prescription that your doctor wants you to take, or what similar medications you could choose, or truly if money is you just cannot afford an expensive medicine, work with providers, work with your pharmacist to go back to those generic medicines that treat that condition.
now, here's a great question, and it's why can't the doctor just prescribe the cheapest option to begin with? Are there incentives, or is it just the fact that the doctor doesn't he or she just sees the prescription and they just prescribe it? There's no reference to how much it costs.
I'm going to use an iPhone analogy. If you're an
Okay.
iPhone, at any point, you could go back and purchase one of the old flip phones.
Mm-hmm.
You can make phone calls, and if you're willing to hit the B 3 times, to get the letter you want and whatever, you can text with it, and that's always an option, and it's always going to be the least expensive option. But if you want a more advanced one that allows you to search the internet, that allows you to take more adequate pictures and videos, faster phone calls, if you want the features, you're paying for the new one. These newer medications, it's not just a racket to make money. Usually they have major advantages, like the accidental side effect that was found of these newer medications that stimulates weight loss. People didn't know that was going to happen, and now there's a huge demand for them for their side effect. And now they're helping heart failure. And now, what did we talk about this morning? They might be helping long COVID, and they might be helping other things. So it's more a new innovation in whatever sector you're thinking about brings advantages over some of the original models.
So it's pretty confusing. Yeah.
Yeah.
Let's see. Is WellCare owned by Region CVS or one of the two other insurance company pharmacies that you mentioned?
No, WellCare, their pharmacy benefit manager is CVS Caremark. So
Okay.
WellCare plans do have CVS as a preferred pharmacy, but no, they're not actually owned by the same by CVS, but that's their pharmacy benefit manager.
Okay. Let's see. All right. But does Medicare Advantage cover you when you travel overseas as an older adult?
Potentially, and that's something they'll list in their benefits package. Some are. It's not really comprehensive, but emergency care, things like that, it should have some coverage. But again, everything changes every year. So definitely read the summary of benefits to make sure if that's something that you are traveling a lot.
Okay. And Tricia asks, can you also discuss the patient assistance programs through manufacturers?
Michelle, I'll let you do that one.
Yeah, those are available for people that usually don't have prescription insurance and have very limited income. So there are criteria for each. I know in my career, I've gotten millions of dollars of those for clients. And I don't think of it as usually applying quite so much to Medicare unless that assistance program decides to allow that as one of the criteria to obtain those medications. But manufacturers have made those available to make medications available to people that really need them for the purposes of controlling conditions.
And how do we find out about those programs?
Their website, typically.
Oh, okay.
And each drug company will have different assistance programs and things like that. Typically, it's going to be for those really high, expensive drugs that are brand name only. But a lot of it's trial and error and seeing if they still have it, if it's available.
And so again, we hope that your doctor or whoever writes the script knows about these, but I guess again, you get a prescription written, jump on your phone and maybe type in that drug and prescription assistance program. Is that one way to do it?
It's one way.
Potentially.
A lot, especially like in oncology, some of these specialty areas, the physician's office might have somebody who does those sorts of things, helps organize benefits for people, or your pharmacy may be able to help as well.
Okay. All right, let's see. So in reality, drug companies are finding ways to get around the $2,000 cap.
It's not drug companies, it's the insurer.
Okay. All right.
So it's the insurance carrier. That's where they're the ones that set the premium prices and all of that. So, and ultimately that PBM is the middleman between the drug company and the insurance company. So the insurance is ones that really make the most decision on the drug cost.
All right. And Cheryl, go back. We're going to talk about coupons and Medicare. She says, with regards to prescription discounts, and because I have Medicare, I'm not provided with the discount coupons to use. Will this change, or is there a loophole that stops me? I feel that it's not right to prevent me from using the coupons. Isn't the goal to use the medication for better health? And wouldn't the coupons eliminate costs across the board? Any thoughts on that?
It's restricted because you're a Medicare recipient. So you are already receiving a discounted benefit. You have coverage. So the coupons tend to be for those that are not running. So if you were to use a coupon, say if someone from like if I was to use a coupon, I have insurance coverage, but I couldn't run that through the insurance. I'd have to pay out of pocket for that. But it's that yes, that's the one caveat, the rub, that if you're a Medicare recipient, you can't use a coupon. That's why you would want to then check into the assistance programs for that drug to see if the manufacturer will potentially have a patient assistance, but you do have to qualify to receive that, and that's typically for lower income.
Wow.
So
Okay.
basically, if you've got reasonable income and you've got insurance, those coupons aren't going to apply.
Okay. So you more than likely you're getting the best deal through the other programs. Okay. Great. Again, Robert gets a gold star today. And the last question we have on the queue here, and whenever I say that, it adds a few more questions, but he says, can I use AI to determine the lowest prices and alternatives? And Robert, here, I'm going to share my screen. I know that this isn't perfect, but I use and I'm curious about our panelists' experience on this. I use Perplexity, and I typed in, can you find the cheapest cost for Ozempic for me? And it brought up retail prices without insurance. It's got a handful: Costco, Kroger, Walmart, CVS. And then it tells me some cost saving strategies. So I don't know if these are complete, but man, I mean, I'm constantly amazed at AI. What is your all's experience with AI and researching drug costs?
I've not actually tried it yet, so it's something to think about.
Okay.
Yeah, it would be wonderful, and perhaps this will be available next year if there were a more AI component to search Medicare.gov and tell the AI, these are my medications, this is my pharmacy, this is my doctor, and then have it do that for you. That would be great.
Mhm.
Yeah, but I'm just blown away at some of the questions that I've asked here. And as I'm looking at this answer, I mean, granted, it's not a drug that I'm taking, so it's hard to know, but there's an Ozempic savings card, there's a patient assistance program, a compound semaglutide
Mhm.
that is radically less expensive. So folks, if you're looking for, drug pricing, I recommend throw it into the AI bots because I find it to be way better than a Google search for sure.
Mhm.
Man, okay, we hit our what I call my maximum time limit, which is an hour and 15 minutes. We hit it on the nose. You all have been incredible. And how about our audience, though? I mean, are
They
these
were
good
wonderful.
questions?
Great
Yeah.
questions.
I know they really drive these conversations. I will get this one right up, and I'm gonna try to share this discussion in as many places as I can because I think it was really beneficial to just understanding this crazy system that we're in the middle of.
Yes.
Mhm.
And somebody mentioned maybe we do this again next year.
Oh, yeah. So
New
here's what I'm
administration
going
in
to
the US.
do. The two of you are the experts, and you have an open door with us anytime. And so if there's some radical changes or even minor changes, feel free to just drop me a line. Steve, time for us to do another Medicare RX discussion, and we can get it up there. And then it's also a great recording for you all to share with the
Mm.
people that you come across as well.
Yeah.
All right. Michelle, Holly, thanks so much. And once again, thanks to everybody. And I see you hung in there, Robert. Thank you because you asked a lot of great questions today, as did others too. So see you all at the next